Well, good afternoon, everybody. Today is sorry, the title slide is incorrect. Today is actually October 9th. You're not having a flashback to last week. You've joined the CAF COVID Weekly Roundup. My name is Jason Belden. I'm the Director of the Emergency Preparedness Program at CAF. And today our guest speaker is going to be Patty Owens, the Director of Regulatory Affairs with CAF. We're lucky to have Patty back. It's 1 o'clock in the afternoon, if you didn't know that already. And this week we're going to, it was a somewhat slow news week in terms of AFLs. We certainly were expecting a big testing or a big visitation AFL to drop, but we have yet to see that. But we're going to cover a few things as it revolves around visitation that we've learned since last week. Tales of caution, we'll say, and we'll give you guys an indication of what that means. We'll talk about the AFLs, some of the testing stuff that we have heard from, and we're going to ask that you kind of give us your experience as you go forward, not just with the antigen testing, but with other types of testing as well. All right, so let's get started. And then, of course, if you have questions about resources that CAF has, you can go to caf.org/resources/coronavirus, and you'll have all the links that we gather from different government entities. All right. So as an introduction, speakers' opinions are expressed are their own and may not reflect CAF's official position. When we get to a situation like that, we'll try to say this is what CAF's official position is versus our personal opinion. This is brought to you through a grant-funded program, and we have no financial conflicts. Both Patty and I solely work for CAF, I think. Patty, you only work for CAF, correct?
Correct.
I think so.
Correct, yeah.
Yeah, okay. And so the intent of the webinars is to kind of give you a situation report based on the week's previous activities. We'll do some forecasting as to what we expect, in the weeks to come, and highlight best practices when we can. All right, so there were two AFLs that came out since last Friday's webinar. One was a grant opportunity to support in-person visitation, and the next one was voting during the COVID-19 pandemic. We've covered the grant opportunities to support in-person visitation on previous webinars. So hopefully you guys have an understanding of, the limitations of that. It's not, an incredible amount of money. It's a small amount of money, but it can offset the cost of obtaining some of that equipment to support visitation. In terms of the AFL on voting, most of the facilities every facility has experience in assisting our residents with voting. In regards to the AFL, it covers all of the things that we would normally do, and it adds in a layer of items that you should be considering for infection control while accommodating the residents' right to vote. Is there anything that you saw in there, Patty, that you wanted to specifically highlight that folks needed to be prepared for that was marketably different from previous years?
No, nothing markedly different. It does speak to the fact that if they want to vote in person, we got to follow the COVID-19, and of course we want to try to get them to do the other, less exposure items first. And you're always going to follow your county guidance as well. So, but it's basically the same stuff we've done year after year, Jason. So.
Okay, feel free. Okay, so I want to hop to testing, guys, because we've heard, a lot of stories this week. Both Patty and I frequently speak to members all across the state, and we've got a lot of questions on how do we treat non-employees. And I'll just say that Patty and I, as well as Craig, had a conversation with Heidi Steinecker earlier this week. And one of we had a number of issues regarding testing, but one of the things we wanted to get clarification on was non-employees. And so for for us, we've heard a lot of questions like, this person's not on my payroll. Do I put them into the employee testing pool? And I'll make sure Patty concurs with this, but from my understanding after our conversation with Heidi was that if they are not on the payroll, they would not be included in your employee testing regimen. Does that sound accurate?
That is accurate because even though they fall into the healthcare provider category, if they're not on your employee payroll, the testing of them would be more part of maybe your facility policies or your contract with those other healthcare type providers, whether it be registries or your therapy companies coming in or your physicians coming in or that sort of people coming in if they fall under the healthcare provider category that are non-payroll employees.
And so that kind of clears up a little of the confusion, and at least it lets you know that it's not mandatory for you to bear that burden. But it doesn't mean that you shouldn't necessarily not ask them if they've been tested, or for you to institute a policy to require certain things. And we don't want to take that ability away from you, but we want you to know that sometimes that can be challenging to arrange for these non-employees to be tested. And if these non-employees frequent 15 buildings, in a week, which one of the buildings is responsible for testing them? So it's a lot of it is, I'm sorry, go ahead, Patty, if you had
I was going to jump in, and it would be a good time to look at your contract with those type of providers, because typically in our contracts, we talk about that whoever we're contracting with, they're responsible to make sure that their employees are free from communicable diseases and illnesses. We usually have them screen for the TB, make sure they have their vaccine, all of those things. So I think that would definitely fall under the testing requirements. So just taking a look at what your contract says with those type of other healthcare providers.
Yeah. I was just going to say, I know folks are concerned on both sides. So the question really is, I think you guys as you sit down in your team to determine what do you think is the best course of action for your residents, it's not, let's just put it this way, there's no mandate for you to test those folks. So it's up to you to determine the safest way to get these folks in the building to do their work. So, I believe there's, did you want to add to that, Patty?
I did. I want to add one more layer because this came up frequently also with some of the providers, Jason, was the employees who work part-time or on call. We also I wanted to speak to that real quick is, you want to show your good faith efforts on getting these employees tested. Granted, they're not going to come in and weekly testing on some of these people. I did specifically ask that question to Heidi, and her answer was that they would be tested just before they, get them tested before they come to work, and show your good faith efforts, maybe put them in a different log, your part-time, your on-call staff, and put that into your plan and your policy and how you're going to meet their testing and make sure that it's, meets whatever your county's saying, of course, as well. But some people were concerned about having to try to get them in for the weekly testing, and if they were supposed to be tested weekly as well. And they did clarify that you just got to show your good faith efforts on trying to get them tested, get them in and tested, and as long as you get them tested before they come to work.
And when we talked to Heidi, that wasn't these weren't the only things that we discussed with her on testing. One of the other things that we talked about was the apparent delays in getting login credentials to get signed up with CalReady. And I think we've learned that there's, many facilities, kind of have a regular process to, reapply or to pay their fees to get their CLIA waiver every year. And with that, there's, you list who it is in your facility that fulfills certain roles. And it may be that what you have on your CLIA waiver is outdated, and it could be outdated by many years. So some providers have seen that and said, oh, we have to rectify that and redo this entire process to get started up with CalReady. And so for those folks, I think there was a part of it that was self-inflicted in terms of there being a delay in getting a new login. Just know that if you're redoing that process, we've been told that there is a delay in getting that login, but be patient and bear with it, and you'll eventually get it. In terms of the sign up and what we've been told, and this is directly out of the CalReady manual reporting guide that they sent out as a part of that AFL. But it's a relatively simple process in terms of what you go through to get your account, get the login. It's just a matter of time to get it. I don't think we're seeing a lot of problems with returned requests to get logins to ask for more information. We're just seeing a long delay in getting a response. So if you're running into that or continuously running into that, please let us know so that we can reach out to CDPH and let them know there's problems with that. So once you go through that process and you submitted that account form, that PDF that's linked there, you send it to that email address, and that's where we're seeing the delays. While you're waiting for that, though, I would review the manual lab reporting quick start guide, and that's linked on the bottom there. And that just tells you what kind of data entry is going to be expected for each test that you do. And it's a manual process, meaning that you're doing data entry of each individual test result for each resident or staff that you're doing it on. So it is a kind of a laborious, time-consuming process. But we do know there are facilities that are actively using that now, and that's important. Patty, do you want to comment on the folks that you've talked to that have started using these devices, or?
Yeah, we've had some. I've had a few reach out to me to let me know that they've completed the entire process, and it can go, believe it or not, really well and smoothly. And we've had several providers who've had a really good process with it, that they've got it set up, they've even got the reporting set up, and they've started the reporting process as well. So they're using their antigen testing, they're doing the reporting on the results, and they've had no issues or glitches so far. So
yeah, so that's good news,
and especially
well. Yeah, it can go well. And if you're running into time delays in just getting the login, know that that's probably going to be the hardest part. Once you get to the part where you're doing data entry, Patty and I have both looked at the quick start guide and looked at what they're asking each individual to, the data that you're supposed to put in, and it does not look overly complex. It just looks like it's going to take time to input each one of these things. So as kind of Jeff, when Jeff came on and talked about how we capture data, to be able to justify expanded costs and different costs, those are the type of issues that you need to be recording to be able to quantify how many extra staff hours you're spending on things, and that turns into a dollar amount that you have to spend supporting doing those events. And so we know if you're just doing traditional labs and things like that, there's still a time that it takes for you to accomplish that. So you need to quantify that as well. But if you're doing these antigen testing devices, recording all of that time that you spend doing the data entry is going to be critical when you justify those costs if you're using the funds from the CARES Act or any of the other funding sources. So one of the other questions we asked was, can facilities use these for visitation? And I don't know that we got a fantastic answer on the second bullet point, but the good news is that Heidi believed that it would be allowed. But an MD order would still be required. And you as quote unquote the lab, because you're performing a lab function, you would be required to report the same. So let's say you have a resident has a family member that's coming to do a visit, and you don't have outside space, you want to do inside space, and you want to test this person prior to entry. Now, we know testing is not a 100% solution. It's just a moment in time that we're taking a picture of. But you're going to have to report that just like like a lab. And one of the last thing, did you want to mention anything else about visitation that maybe I missed from that meeting with Heidi, Patty?
Well, overall, we discussed the fact about physician orders, and there was some concern on who writes these physician orders and who's going to want to write physician orders for people, someone, well, even your own health employees or visitors. And so there's both a concern in who can write those orders. Heidi is going to get back to us with further clarification. We really pushed that for clarification on our last call. Supposed to get us back very specific clarification from all the member questions we've had on this. And as soon as we get that, we will post it on the forum and we'll get it out to everyone, her exact answer. And that is regards to getting an MD order still required, because it's part of the requirement for the point of care testing devices as a physician order. And that gets complicated when you're dealing with who's going to write an order for visitors, the employees, etc. So stay tuned on the answer for that directly from CDPH so that it gets interpreted correctly across the board.
Yeah. But at this point, we're assuming that an MD order is required for any time you use the antigen testing devices. Hopefully we can get some clarification, or maybe even talk about doing standing orders and things like that. So all of those are in the discussion, but at this point, for right now, you want to continue to make sure that your medical director is ordering the tests. All right. And one of the last things I wanted to get to on testing was the fact that we're now starting to retest people after 90 days. So folks that have previously tested positive, whether it be a resident or a staff member, we're putting those people back into the pool of testing post 90 days. And I just want to say that 90 days is an arbitrary mark that the CDC has kind of put out as a target for when theoretically somebody should stop testing positive. And what we found, well, there are a lot of folks that are post 90 days that are testing negative. And I would say that's the majority of them. But there are examples, and more than just a few, of both residents and staff testing positive 90+ days after their exposure. And in those cases, some of the specific cases we have passed directly to the health department. And depending on where you are in the state, your health department may want to do its own investigation. The thing is, when we look at residents that are post 90 days that are being identified as still positive, whether you tested them through your, whether you're in Los Angeles County and they're included now in your screening testing for residents, or you're in one of the other health departments and you're retesting those residents as a part of response-driven testing, you're going to find, I think, that there's going to be a percentage of them, and it may possibly align with, how well they overcame COVID symptoms. So if they were potentially symptomatic for a very long period of time, the chances of them staying persistently positive appear to be higher. There's been no specific data or research that I can find that says that, but everything is kind of hinted at. The folks that struggle to recover from COVID and they struggle with symptoms of COVID seem to be more likely to be in this bucket where they stay positive. And we've even heard cases where the resident is put back into the screening pool and they test negative after 90 days. And then on day 110, they will test positive again. And then the next week, they'll test negative again. So there's this, what we want to do is we want to get away from the doing whack-a-mole, and we don't think it's appropriate for these folks to constitute a new outbreak. So it's important for us, because if you guys are doing response, an outbreak, it's possible you could be on an admission ban. You're going to, have staffing models that'll look different. You're going to have to do, robust testing of everybody twice, including all the residents. So we want to avoid doing that stuff unless it's absolutely necessary. And so what we want to do with the residents is much easier for us to track, or much easier for the health departments to track exposure versus what it is for staff. Imagine your staff leave every day, so they have new opportunity for exposure. Your residents theoretically would have much less risk of new exposure, especially if we've done testing subsequent to that positive test and determined no further spread. We know that those are specific to persistent positive tests. In Los Angeles, what they're going to do, I've given them enough information on facilities within the county that they're going to do some viral cultures on the residents to be able to determine whether they're new infections or not. But I think once they are able to do that, they can do a countywide kind of guidance on how to handle the retest being positive after 90 days. But at this moment, they're still constituting that as a new outbreak. And so we need to gather this data as quickly as possible, especially before visitation opens back up and we have all new exposure risks to the residents. We need to kind of quantify this and get that, either the metric, the 90-day metric has to be moved, or there has to be some kind of written kind of guidance on how to clear this rather than calling it a new outbreak. For the staff, it's going to be a lot more difficult, because we do know that clinically there's not a lot of data. I was only able to find 2 cases of true reinfection that had been researched and confirmed through peer-reviewed or peer review, and but those are the only 2 cases I found. But still, theoretically, it's possible to get reinfected. And so I don't think the health departments could really come off the staff requirement, but we may be able to move that 90+ days out if we can show that 90 days is not a reliable metric for when somebody stops testing positive for coronavirus. Did you have anything you wanted to add regarding the retesting after 90 days, Patty?
No.
Okay.
Well covered. Thank you.
Oh, sure. So I just want to get the visitation. If this looks like a repeat of the same slide from last week where we said AFL pending Monday ? Yes, that's the same title for this slide. We do know, based on the conversations we've had with Heidi and what I've heard her say on the HAI calls, is that you can anticipate quick implementation of whatever the requirement's going to be. And I think she made that very clear that, that would be probably an expectation that you guys would hit the ground running once the AFL came out. And I wanted to talk for a minute about outside visitation. And I've talked to 2 specific facilities, but one in general this week that would give me a tale of caution for you guys. And this goes for all visitations. It will be even more concerning when we go to indoor visitation, but we know that families are clamoring to touch their loved ones. And I've told people when we were talking about developing this visitation guidance that if it was my mom in that facility, I would have a really difficult time not wanting to give my mom a hug. And I don't think I'm unique in that. And so we know there are people that view risk to coronavirus, as they're more flippant about it. And that will include some of the people that come to visit in your facility. Now, we had a case where a facility was proceeding with outdoor visitation. It was in, the resident was on hospice, so they did not have a good prognosis, for many months in advance, in the future. But the family members decided to discard the direction given to them by the facility, and chose to go around the table and the plexiglass barrier that was set up to give their loved one a hug. And consequently, that person tested positive for coronavirus 2 days after the visitation, and the resident tested positive 4 days after the visit. That resident has since expired, and there were 3 healthcare workers and 1 resident that got COVID from that exposure from that resident. So now the conditions were perfect for this to happen. The air was still outside. It's possible that the people that were overseeing the visitation may have taken their eyes off the situation. So it's a combination of things that led up to that. But it is a tale of caution that even a short period of time within, a really confined space can lead to poor outcomes. And I'm not going to say that is the rule. It's clearly the exception, but it does mean that we have to, when we look at this visitation, we have to explain to these visitors, we're not just worried about the safety of your loved one, we're worried about the safety of everybody in this building. And so please respect the fact that we have to follow these guidelines, because it's a matter of life and death, potentially, if we get it wrong. And so that leads me to the indoor kind of concerns around infection control and indoor air. So many of you may or may not have seen this, but finally, I've talked about this on this webinar, gosh, more times than I can count, but finally, CDC has acknowledged cases of airborne spread under limited circumstances. And I would say that's another effort to kind of minimize what we have seen within nursing homes throughout the country. But we do know that, and this is a quote from the CDC, some infections can be spread by exposure to virus in small droplets and particles that can linger in the air for minutes to hours. These transmissions occurred, and it went on to state that these transmissions occurred within enclosed spaces that had inadequate ventilation. And so I want you guys to think about, the built environment that you currently operate in. And I've been in a number of skilled nursing facilities where I would say they fit the very definition of an enclosed space within, well, maybe not inadequate ventilation, but certainly minimal ventilation. How's that? I don't know how to, inadequate would be anything less than, massive air changes per hour. So I think that's, it essentially means that, if you were going to draw up a problematic indoor environment in which to house people with a highly infectious disease, an older skilled nursing facility would be right up there on that list. And so when we talk about these things, they're talking about how it's spread in the air in normal environments. Our environments are a 24/7, 365. And so if they never, the residents never leave those enclosed spaces. So they're constantly at the same risk level 24 hours a day. So it's, this is more like, duh, yeah, we knew this, we could see this. We know we followed infection control guidelines, and we still saw outbreaks and spread. So now what? What do we do with this information now that we know? a lot of the problems with our response to this, and for all of us, you know, Patty, myself, Deanne, all the team at CAF, we all, when we sit around, the hardest part is not knowing what we don't know. And I know that's hard for you guys, because you go, well, what am I missing? Is there anything I'm missing? And I just want to cover what we do know and kind of re-encourage you guys that the work that you're doing may be all that you can do. And so when we talk about, you know, how it spread, what are the things that we can do to prevent this? We know that 6 feet is still going to be recommended when possible. So we, even if it can, you know, stay in the air for a significant period of time, even when the it can be over 6 feet, we still want to encourage that kind of physical distancing. Source control is a big one. You know, in doing research to kind of look at best practices across the thing, I came across a study that was done about the effectiveness of just surgical masks versus wearing no mask. And that's a big chunk of what we do. And how you feel about masks personally, or I hate that this has to be a thing that we talk about, but it's really important, not just at work, but wherever you go. Masks, you know, you should be wearing those at all times. And then in terms of the when and where, understanding when it's required to implement those transmission-based precautions and following those to the letter to the extent possible. Hand hygiene is incredibly important. I don't have to belabor that. You guys have been told that, but ABHR, soap and water, all good. Avoid crowded indoor spaces. And we don't really recommend what you guys do outside of work, but these, if you look at what your personal risk is, and if you want to minimize that, these are good spaces to increase your risk if you want to. So, but I would, me personally, I minimize that. And there are some places you can't. You got to go to the grocery store. You know, you got to do certain things. But, you know, in terms of a choice to spend my hours outside of work, they will be spent outside and with a smaller group of friends. Hopefully you guys are already doing that, and limit the circle and stay away from those crowded indoor spaces. Routinely clean and disinfect your surfaces. And, you know, COVID can be made aerosol again. So if you're cleaning ineffectively, you could be producing particles that go back into the air again. And so then that, you know, all this stuff, you're going, well, gosh, we're doing all that. So great, you're doing best practice and all that we know. Now let's talk about the indoor air of your individual facilities. So if you have air conditioning in your building, or some kind of central air in your building, we want to max out whatever the fresh air you can bring into the building. So there's, you know, most of the package units have a fresh air vent. You want to make sure that it's opened as far as possible. Our suggestion is to run your fans continuously. They can be set to not, well, not every unit is the same, but they can't, some of them can be set to run continuously, the fan, rather than cooling or heating. And so we want to keep that airflow, even if you're not heating or cooling the building. If you don't understand the air changes that you have, especially in the areas where you're planning to have inside visitation, you need to understand that pretty quickly. And to the extent possible, you know, maximize the amount of airflow that you're pushing through your system to increase those air changes per hour. And the air changes per hour has a guide for when you can reoccupy certain spaces based on the total air change. Now, we've talked about how you measure your air changes per hour. There's a mathematical formula that I put on a link on previous AFLs. But essentially, it requires an anemometer. I'm drawing a blank on the technical term for it, but it's basically a fan blade that you hold up to your fresh air vent, and you hold that there, and it determines the amount of flow of air. And you multiply that by the space, the total volume of the room, and it will give you your air change. And then based on that air change, will tell you when you should be reoccupying those spaces. If you do not have air conditioning or some type of central air to move air around the building, improve the ventilation and open windows to the extent possible. I realize that smoke is still an issue in areas of the state. And for those places that have air quality issues with bringing in fresh air, whether it be from your air conditioner or whether it be from opening the windows, you can consider adding commercial air scrubbers or filters to help filter out some of those contaminants from circling through the building. If you decide, you can purchase air purifiers, and in many of their industries, those are being recommended. So if you think about schools as they're thinking about opening up, restaurants, coffee shops, things like that, are talking about air purifiers. If you decide to purchase a portable air purifier, just know that those also will help increase your air changes per hour. There'll be a kind of a label within the air purifier that tells you how many air changes they do, and you'll add that to the amount of air that's coming through the vent, and that'll help you determine what your air change is. It could theoretically drop those air change or the times that it takes to reoccupy those spaces. And as an added benefit, they have HEPA filtration, which filters out COVID. So that's a really kind of good step, but it's an expensive one, and it's not something that you could apply to like well, I don't know, it's probably not likely that you could afford to buy that and set them in every room. But I would, as you kind of focus on this, if you want to do something like that, I would, if you have finite resources, I would, concentrate those air purifiers on areas where folks congregate. So think the common areas, maybe staff break rooms, wherever you're going to have the inside visitation, things like that. As you look at filters for your HVAC system, we want a MERV rating of those filters of 13 or higher, and we know those are effective in filtering out SARS-CoV-2 or COVID. And in areas where you're doing high hazard or aerosol generating procedures, the recommendation is to have a MERV rating of 16 or higher. So just so you guys know about what the MERV rating is, I realize some of you may have really old systems that will have a hard time pushing air through. So the important thing is to make sure that we get enough air changes going through those things. And if we can, we want to add the MERV rating to those filters. We do know that if you have to use fans, we've talked about this before, but we want them to go from the clean to the dirty. In other words, we don't want to set a fan at the headboard of somebody that's in one of the red zones, because it's going to blow air from the infectious person across the room and potentially out the door. So we want to make sure that we're creating those directional airflows so that we're not pushing air from folks that are either positive or suspect cases. There are UV, ultraviolet light devices that can clear surfaces in resident rooms, and I know of a few facilities that are using those UV devices. They're kind of like little, almost like an iRobot, except much bigger, and they use UV light, but it's kind of a set it inside the room, close the door, runs its cycle, you come back, you move it to the next room, that kind of thing. So obviously nobody's in the room when they do it, but the room is clean after that. And those devices are expensive, but they're very, very effective. And the last bullet point here, we want all of these things to be kind of factored in. Even if you have, all of the ability to, run your HVAC continuously, we want to combine the effects of outdoor air filtration and air cleaners exceed what the minimum ventilation requirements are. So when we talk about these are all tools in your tool belt to kind of help, your indoor air quality. So no tool is 100%. In order to get the best results, you need to use them all the time. And it's important to note that aerosols containing SARS or CoV-2 or COVID has been found in 63% of the samples from isolation rooms. And so they've taken samples off surfaces and in the air from, this particular study that I'm citing was done at the University of Nebraska Medical Center, but it was done in rooms of infectious patients. It's a stark kind of reminder that absolutely that is in those rooms. Now, does that mean that if you're fully protected, you're walking through this waft of infectious disease? I don't know, but it does mean that it's possible. And the other thing is, does transmission of SARS-CoV-2 occur by aerosol inoculation of the ocular surface? And so I've had a lot of questions about, gosh, now they're requiring, eye protection even in the green zone. And so this is the reason why they have come to that conclusion. There's a study that's cited, and it's linked. If you go to that, the full research paper is linked there. But within that, they have the study that was done on the ability for this to infect the eyes. So when we look at eye protection for our staff, they may be hesitant or not want to do it, but I encourage you guys, and I talked to Dr. Namali Stone from the CDC, and she concurs that she thinks it is one of those things that we've not looked at, and maybe it's not the primary transmission mechanism, but it's certainly possible and maybe even probable. So her suggestion was to do extended use of the eye protection as well as the N95s, because if you don't, you're essentially pulling those things off and cleaning them after every interaction with the resident. So my suggestion would be to do what Dr. Stone recommends, is to implement extended use of the eye protection even in the green zones. So, Patty, did you have anything else you wanted to add on the airborne spread? I know you and I have talked about this ad nauseum for months, but yeah.
No, I don't. I think you've covered everything pretty well. I mean, as we move forward, we'll probably be talking about this a little bit more. It's something we probably, like you said, we've already all suspected. And moving forward past pandemic with COVID-19, we have to look to the future and how we'll be doing business in the future, and what type of infection control practices we'll have to put in place. So those are all things we'll be thinking about moving forward. And I don't think we have the real answers yet at this time on what that's going to look like.
Yeah. Oops, sorry, I put myself on mute on accident. So with that, guys, I want to get to questions. We got about 15 minutes this week. We do anticipate the AFL for visitation to drop any time now, so that will definitely be coming out this week. I don't have a preview of any other AFLs that may be dropping. Patty, did they mention that they had thought they were going to? I believe, we do believe, if you're an ICF facility and you're on the call, we do believe that at some point there's going to be a testing kind of mandate on ICF providers fairly soon. So we may see that this
Correct.
week. Mm-hmm. Yeah, and is there anything else that we thought maybe is on the horizon for coming out this week? I think that was it, but I don't.
Not that I can recall, Jason.
Okay. Yeah, and I thought that was it. So that's good news. If all we got to do is in the next week is kind of implement this visitation AFL, I think we've got a good idea of how it's going to happen in our building. So it should take nobody on this call by surprise.
But to add a disclaimer, they love to surprise us, so we never.
Yeah, that's true. They don't always let us know, for sure. So I want to hop to questions. One of the first questions was, how do folks access the forum if they hear us talk about the forum and reference the forum? If you guys are not currently on the CAF forum, what I'd like you to do, there's 3 easy steps. You're going to send an email to Heath, and I'm going to spell this. It's HRENOUF at caf.org. So Heath, and that's Heath's last name, Renouf, at caf.org. In the subject line, indicate CAF forum request. And then in the body of the email, just put your first, last name, employer, and company email address. And we will get you signed up for the forum to make sure that you get all the information from the forum.
And I
So
wanted to
hopefully
add,
that, yeah.
Jason, real quick, I just want to add that the CAF forum, a lot of people think they're already part of the CAF forum because they're a CAF member and they got a CAF member login and stuff. The CAF forum is completely a different thing. It's an email forum where we all talk to each other. It's a private group. You have to be vetted in. You get it signed up to be on the email group. And so it's a completely different thing. Just being a CAF member and having a membership login it doesn't give you that.
Yeah. And we would love to see the forum grow. We would love for all of us to share best practice on those things, especially nowadays when we, I think Patty and I would both agree that we feel like we're constantly fighting off negative press and constantly fighting off trial attorneys and advocates and things like that. So I think as a group or as a provider group, it's super positive for us to be able to have that kind of feedback from each other to bounce ideas off. So I encourage you, if you're not signed up for it, please sign up for it. Patty and I and all of the team at CAF is usually very responsive. So if you have a regulatory or specific question, we're happy and we answer those as quickly as we can get to them. So I encourage you to sign up for it if you're not. All right, so the next question, somebody put check date, not October 2nd. And oh yes, check date on the title slide. Yes, okay, sorry, yes, sorry, there was a typo. That's my fault. Can you please clarify QSO 2038 considers those providing services under arrangement needs to follow the table of positivity rates to be tested? Is CDPH considering these providers as healthcare workers of the SNF? And well, I can say that what Heidi told us is the metric that they're going to use is, are they on your payroll? And so that makes it a pretty easy kind of yes or no of whether they're included in that QSO. Do you agree with that, Patty?
Yeah, because as far as regulatory goes, there's no way for them to enforce CDPH to enforce it, any of this on anyone else, only residents and employees. So other agencies or outside sources, they don't get to tell them what to do. And but of course the facility has to do best practice and protect our patients, and how we do that would be within our policies and our contracts, I guess.
Yeah. And we had another question. I'm sorry I didn't see this right as we started, but it was in our mitigation survey yesterday. CDPH stated per the AFL, all staff should be wearing face shields even in the green zone. And that I think we covered that as to why well, at least the why that the rule is the way it is, specifically because of that potential ocular transmission. It's really hard for us, especially if they have data that backs up that decision. It's really hard for us to say, no, you shouldn't do that when it's contrary to what the research has shown. I had a surveyor in the building yesterday, and they stated that vendors should be weekly tested, and that's in Orange County. And so I can't really comment on that. All I can say is that was the directly from the horse's mouth, or well, I don't want to say the horse's mouth, but directly from the boss, that the person who's in charge of all licensing
Well,
gave us.
it's not
Yeah,
unusual for us to get inconsistency on enforcement across different district offices. And if you run into one district office going in and telling you something different, you can always elevate that over to me, and I can reach out to the Sacramento headquarters, to the branch chief as needed, and make sure that that district office knows the correct interpretation of the guidance and is enforcing it correctly. Okay. If you need that, you can email me and I'll help you. Email me in a way that I can share that email with my contacts over at Sacramento headquarters. That way, you'll know that I'll be sharing that with them.
yeah, and that applies. Patty's great about it, and frankly, she's been overwhelmed with the amount of kind of inquiries and inconsistencies for 6 or 7 months now. But it's something that we continue to do, and please, if you need help with that, Patty and I are happy to jump in any way we can. So I had a question here. Does LA County use CalReady? And no, they do not. LA County's reporting is going to be different. And I've talked to Dr. Gounder about how LA wants to do it, and they're only concerned about the positive test. So, it's funny. I don't know how they're gathering the data, to provide that to the feds. But as of now, LA County does not use the CalReady system, nor does San Diego, I believe. So if you're in one of those two counties, please disregard all the stuff about CalReady. It does not apply to you guys. Our lab X-ray techs needed to be tested weekly too. And then I think, how about families that visit? And that was one of the kind of contract or vendors that we talked to them specifically about lab and X-ray tech, and she said no, they would not need to be in that testing pool where you're doing it, but it would not preclude you or prevent you from having your own requirement to do that. So, and then how about families? And we discussed that with Heidi, because obviously that is a whole new vector of a possible infection coming into our buildings. We can't require them to be tested, but if you've got the ability and you've kind of gone through that antigen testing process, you can perform that service if you want to for them, or you can ask them if they've been tested. That's quite within your rights. I think what we have to do is we have to understand that not everybody can do it, and not everybody's going to want to do it. What we can control is we can control their access into the building. We can control what they do when they're in the building, or to some extent. We can make sure they follow source control. We can do screening questions. We can do all of those things that will help. Remember, it's not no tool is 100%. Each one of these things give us help. But you don't have to require, or you're not allowed to require them to provide a negative test before they're allowed to visit. Can we ask the non-employee for proof of their COVID-19 test? And so that goes back to you setting your policies and procedures that are going to be specific to you, and whatever works for you.
And I wanted to add in on that, Jason. You have to be really careful with some of that, is because if they're not your employee, there's some HIPAA violations there. The other contracted type people may have to just show their proof through the agency they work with, and then that agency just has to verify that they're cleared and negative to you. Because to ask them for any of their test results or any kind of testing, just make sure you're aware of that. These different type of people have the right to the HIPAA. That came up with the ombudsman issue with some facilities were asking the ombudsman for their proof of their testing, and was a little crossover with their HIPAA rights. So we would just want to make sure we want to make sure they're cleared to come into our building, and maybe just ask that, that they've, part of that clearance is knowing that they they're getting their testing and they're negative, and that means they're cleared to come in, and then what that looks like, it'll be different with each type of contracted vendor you use or source that you use, and how they're going to let you know their employees are cleared to come into your facility.
Yeah, and one of the recommendations Heidi had was to kind of have them sign an attestation that basically says they're testifying that, you know, they've met the whatever the criteria is that you set. You know, asking them to sign the attestation saying they're symptom free, you know, things like that, that they've had a negative COVID test. You're not asking to see a, you know, copy of the results. You're just asking them to certify that they've done it and they're negative, you know, things like that. Those were kind of recommendations or workarounds that she had suggested. Patty also suggested, and so if you're a part of a group of providers listening to this that go to other facilities, so if you're a vendor and you're listening to this and you're going to other facilities, you may want to think about having, getting, you know, something. If you're a company and you have multiple people going to multiple buildings, maybe as a company, you have something like a sticker or something that says, I've been tested. And then you can tell all your clients that say, look, if they're wearing that sticker, that means they've gone through this process and we've required our staff to do X, Y, and Z. And Patty's suggestion was to have the, you know, the surveyors, you know, do that same thing, similar to what they do during the flu. And so I was just thinking, gosh, if you're a vendor, yeah, same with ombudsman, there should be some kind of visual representation that you know what the requirements are and that you are certifying that you met those requirements. So that's just an idea. Yeah.
And in addition to that, we want to make sure, I just want to make sure while we're talking about that, that alone wouldn't be admittance into the facility. Make sure you're still screening anybody on entrance as well.
Right, yeah. But that may, you know, kind of give you a visual in terms of whether they've been tested or not. And so a lot of questions about this. So it is definitely tops of folks' minds. So how do we deal with transportation companies for our residents, for example, going for dialysis? They need to come into the building. So, well, obviously that you screen them before they come into the building. They're following source control. They're doing everything that everybody else is doing in order to get into the building. The only difference is, you know, whether we're going to make sure that they're tested first. And I think if most of these transportation companies are doing their own internal testing, but it's time to ask those vendors and say, what are you guys doing in terms of testing your staff? Because I don't have a requirement to test them, but I want to make sure they're tested before they come in. And so I think it's appropriate to ask those vendors to see if they have a company policy and what it is. But you definitely, they go through the same screening no matter who they are before they come into the building. Did you have anything you wanted to add on anything else on the transportation drivers?
No, nothing.
Okay. So what proof of or documentation do we need for people not on the payroll? Now, I would just say that's, I don't need, you know, if they're not on your payroll, they're not your employee. So I think it's pretty self-evident.
It's not covered under this. Of course, there, you know, in the future, you got to look at liability issues, who you let in your facility, and you're going to have to stand before and justify your practices, obviously. So again, you're going to have to make sure you're looking at what's required by your county, what's in your policies, and what's in your contract with those outside sources. But there's right now, there is no requirement, but you could set your requirement of what you want to see from those people. So, and within the HR and legal boundaries, of course.
Yeah, okay. Sorry, there's a good question here I wanted to get to. Oh, if you have an employee that works in more than one building, could rotate testing so that each building shares the burden of cost? Absolutely. That's I think that would be a great workaround. Talk to the other buildings, say you test week 1 and 3, and I'll test week 2 and 4. I'll share the results, you share the results, and there you go. So how will that affect the requirement for weekly testing of employees? So if they're working in your building that week, you're going to count them even if the other facility did the test. You know, it counts as a test, and you don't have to both test them. So absolutely, I would encourage you guys to reach out to those other facilities to you know, pool your resources to make sure that not one person is bearing the brunt of having to do all that stuff. And it will fulfill the requirement, and I've heard that on the HAI calls on multiple occasions. So the CDPH is okay with that. If you choose to test non-employees on the point of care machines and they test positive, do you include them on the reporting on CalReady? And yes, you would. That brings up a good point, though. Do you report them as a staff member testing positive on the NHSN reporting? And I don't know if I know an answer to that. Patty, do you know an answer to that? I know for sure you have to report it in CalReady because you got to report negative and positive.
Can you repeat the question, Jason? I got
yeah. So if somebody chooses to test a non-employee using the point of care device, do they need to include that reporting on their NHSN or daily reporting?
Well, under your CLIA waiver, if you're providing any testing and the requirements for the use of the devices is to report any tests you've done, I would say yes. And that's why we really need to look at when we're starting to test these other non-employee people, what the process is going to be, and have a clearer defined answers for this, because you're serving as a lab basically at that point. And if you're doing other people, you're now becoming a public lab, not just doing your residents and your employees, and that opens you up to different things. So I think that's something we're really going to have to get more clarification from CDPH and on that.
Yeah, I agree, but you definitely have to report at CalReady. We'll get some clarification on the other reporting things to see if you got to report.
Under your CLIA and your lab certificate, anything you do like that, you have to report, but not with it's not something for your CDPH reporting and your weekly reporting. It's just for your reporting under your lab.
Yeah. And I had another question about the after 90 days and staff still testing positive. Well, I know that on the HAI call that when it came to staff, they were posed that question. We have a staff member that's tested positive after 90 days. We've gone through, you know, the response testing, and nobody else tested positive. They were pretty confident that this was a case of persistent positivity, and Dr. Epson said that would not be considered a new outbreak. But that's Dr. Epson's opinion from CDPH, and those decisions for whether you need to institute response-driven testing or quarantine or whatever the remedies are, you have to clear that with your local health department first. So that's great that Dr. Epson recognizes that, but I've talked to multiple health departments that still don't recognize that. And so I want you to clear that with your health department first. And I know for sure in Los Angeles, they're still treating it as if it's a new case until they can get some kind of data that would indicate that these are not new infections. And they're going to do the research on that, but until they finalize that, they're still going to do that. And I suspect that's going to be the case in most of your health departments. So definitely, that's one of the ones you want to clear with your health department first.
And it with the AFL that came out, unusual, outbreak, it does count as an outbreak. So you have to follow that as well.
Yeah. All right. So we went way over, guys. I apologize. I hate to take too much of your time up. Hopefully you have a wonderful rest of your what's left of your Friday, and have a great weekend. I realize it's a holiday for some folks on Monday, so hopefully you guys enjoy your 3-day weekend. Thank you, Patty. Thank you for all your help and your expertise. And thank you to Jamie.
You're welcome. Thank you, everyone.
Thank you, guys. Take care.